committee. My name is David Hale, representing the Missouri Hospital Association today, and I'm referring to support Senate Bill, Senate Committee Substitute, Senate Bill 739. I've distributed a document that is very brief, but it does mention several principles that the Missouri Hospital Association supports. We believe that this bill moves in the direction of supporting those principles. We are very much in favor of reforming the current system, and we believe that includes delivery model reform, not only for Medicaid managed care, but also orthopedic services. We also believe that there are reforms that need to be made in terms of the individuals who receive the care and how the state manages that system. As is currently being done for your appropriations last year, the system is being updated. We think there are ways that can be managed for more efficiency, can save dollars in the system, can provide better care for our patients, provide a win-win for the state and the providers and the insurers that currently operate in the system and those that would like to operate in the system. I would keep my remarks brief. I know there's a lot of folks here that, at least I assume there are, that wanted to testify, so I'll leave it at that. And anyone has questions that we have to answer.
Questions of this witness? Senator Shaw.
Thank you. Dave. Are you aware of any ACOs that are being formed in Missouri?
In Missouri, there are several ACOs in the Medicare system that I don't believe there are any in the Medicaid system today. That would be fairly certain in saying that there are not. I never like to say I'm speaking before a committee, but I am told, and would be happy to find research and provide it to the committee, that there are some Medicaid ACOs operating in that state, but I don't want to state that without researching it myself. It's something I was told recently, and I want to research that and provide that to the committee as true. I will say that the ACO model is one which would allow providers, whether it be a pharmacy, a hospital, a primary care physician, even an insurance company, to coordinate the care of an individual. And that's the whole purpose here is managing care. And the point I would just make to the committee is that there are several ways to manage care. Those ways are, there are some of those models that Missouri currently employs today, including healthcare homes, which the senator also has as an element of the bill. And that healthcare home is a great example of what an ACO type of product would look like. It's not a healthcare home is not an ACO, but it's an example of coordinated care. And that's coordinated care is simply better management of the care of the individual. And what we're all, I assume, seeking to do is find efficiencies, create a better system, find better ways of managing that care. We've all heard a lot of stats and data hanging around, particularly over the last 12 months. We've had many committee hearings on the subject. And it's no secret that there's, at least in the hospital arena, there's about 5% of the patients that produce 50% or so of the cost in the system. These are individuals with multi-disease mode, and they require a lot of attention and care to make sure they're taken care of. They also are frequent contributors to the ED. That happens both in the managed care corridor and in the fee-for-service. So there are ways that I think this bill addresses the need to better manage that care, save the state dollars, and certainly moves in the right direction. Now, I couldn't finish my testimony without stating that there are obviously elements of the bill that we would like to see to be changed, but we certainly think that the Senator's Romines bill moves in the right direction. Medicaid reform for Missouri.
Is an ACO basically a provider, usually a hospital, that receives the premium dollar and then sort of divides it up among all the providers that touch the patient? Would that be a description of what an ACO is?
Correct. It would be a coordination of all the elements of care, whether that's hospital, physician, pharmacy, et cetera.
Basically, they receive the premium and then they sort of agree among themselves how to divvy up the payment. Is that kind of correct?
In that model, there are varying degrees of what you're stating as far as how that can happen. So the model that you're describing would allow that group that would be in the ACO to coordinate the care and share the savings.
Share the savings.
That would happen for an agreement with the state or the federal government, as it's the case today with most of the ACOs. But it is new. There's no question that this is a new direction in the provision of care today. And
I'm just trying to get a handle on exactly what it is that an ACO is. And I think what it is a managed care company, why they receive a capitated payment and then they contract with providers. And then any savings that they achieve goes to them or their shareholders. Whereas with an ACO, it's more that the providers kind of come together and create this entity. They receive the capitated payment, and then they sort of share any savings. And they're also at risk for any negative savings, correct?
well, the issue of risk is a question that needs to be addressed and discussed. I think that is something the department is looking at, the senator is looking at in the bill. The ability to flip the switch overnight and do something they can do, like an ACO, management of care and coordinating care, in a capitated environment, meaning sharing risk, as you just described, it would be very difficult. So there needs to be an evolution, which is, I think, the way to do it, and see how, and cooperation with the department, see how we can evolve this to the point where it would work in an environment where there could be some shared savings and possibly even shared risk. But that is not something that would be possible overnight. And I would simply also state that, when you're looking at anything new, whether it's the healthcare industry, whether it's any industry, there's always fear of, is this going to work, is it not going to work? But the MCO model has been around for some time, as we all know. It's been around in Missouri for some time, about 18 years, as a pilot. And we are not opposed to that being one of the options, as is the case in this bill. However, we would like to see and fully support there being other options in the bill and in the state system as a model of delivery, which would include ACOs and healthcare homes. And even though that they are new, and they, as I said, I'll find out if there are some in the state that exist in the community, but that doesn't mean that they don't work. And I would suggest that in the healthcare home, on a coordinated care, just the principle of coordinated care, which is what we're talking about, they've proven successful.
Usually these ACOs are, well, usually in order to form one, you have to be a fairly significant entity. And isn't it true that most of them are hospitals that they're built around, or they're kind of started by a hospital?
The Medicare ACOs that I'm aware of are hospitals.
And so So the bottom line is that the Missouri Hospital Association sees this as beneficial to the hospitals in Missouri.
Well, I would suggest that our position is that we see it beneficial to the state to have more than one option for choice for providers around the state, because I would simply say our perspective is one size does not fit all. And what works in southeast Missouri may not work in St. Joseph, Missouri. And we think there needs to be opportunities for other what types of delivery and competition to develop in Missouri. And this model is one that's relatively new, but healthcare homes have been coordinating that care, has proven to save dollars in the state, and particularly for these high-risk individuals. But if it works in a high-risk environment, for instance, a high-risk individual, the cost of state and Medicaid is quite the most money. Why wouldn't it work for someone who is healthy and doesn't take a lot of money? So, I guess what I would argue is that it's not something that we're arguing as a benefit to the hospital association or the hospital, but we think that it is an advantage to the state, and it makes sense to have more than one choice in the market for Medicaid, and it makes sense for the state to have more than one choice, to have more than one model in the state, to provide the competition and to allow innovation to develop in the state, to find those efficiencies and save the dollars.
Okay, thank you.
Senator Smith.
Thank you, Mr. Chairman. Just some questions. So, is there any data as it relates to Medicaid ACOs in the country? Medicaid ACOs?
Well, as I stated before, I've heard that there are a few out there. I can't state that with surety. I'm happy to research that.
Right, but your testimony today is to advocate for putting billions of taxpayer dollars into a program that we don't have any data for, though.
Well, Senator, today you have a fee-for-service program that pays a provider for that service. And I'm not here to advocate the continuation indefinitely of that model. I'm here to advocate the evolution of that model to other types of other ways to deliver service. But I would simply say that that if it works if the federal government believes that, and I'm not advocating the federal government knows everything, and it works for the federal government. But if these models work in the Medicare arena, which is billions and billions of dollars, and they have been shown us they've been there, and we show that healthcare homes coordinating care, which is really what I'm arguing for, is coordination of care, works, which we've shown over the last 12 months, at least in Missouri, then why wouldn't we try? Why won't we do it?
Well, I'll tell you, one reason we might not is because we're dealing with a particularly vulnerable population with the ADD. To use as an example, a small example of trying to address the needs of that population in insurance reform, for example, the autism bill, took about 4 to 5 years to build consensus with stakeholders, a blue ribbon panel, legislation, discussions, negotiations. And you're talking about $6 billion in taxpayer money that I would argue that the way we're doing it isn't maybe the most efficient or the best way to do it to provide care. But you're advocating for a specific model. And those are what my questions are about. So do you believe ACOs should be full risk? What happens if they don't pay the providers?
If an ACO doesn't pay a provider, correct, they'll be in violation of a contract, and there's plenty of reform in the bill that deals with how providers should be paid. There's laws in the books on how providers should be paid. This is something.
But if they're not, my question is, if they're not paid, who's responsible?
If a provider is not paid by an ACO,
Correct.
well, the ACO would have to pay the provider.
Now, my question is if they can't pay the provider. they mismanage their funds, if we don't have proper oversight, if there isn't a bonding requirement, or they don't have to pay money into the insurance, who's responsible for that then?
Well, I would assume the ACO is responsible.
Well, no, they don't have any money, right? They don't have any money to pay their providers, so they're who's responsible.
Senator,
Could it be,
I don't
could it be
have
the
all
tax, could it
the,
be the taxpayers? Is that maybe the answer that is difficult to give?
no, it's not difficult for me to give an answer because I don't have all the answers for you today, Senator. But I will say that just because something is new does not mean that it won't work.
Okay, which is why we're having a hearing and why I'm asking questions about a specific model that you're advocating.
I would be happy to entertain, further language which would detail out how you want to ensure provider to pay or how. If there's language which you would like to add or you're concerned that meets the concern that you've got, then let's talk about it.
Well, I mean, part of the overall discussion here is there's nothing to look at anywhere. So we're creating this out of, whole cloth now. So I think the discussion about oversight and protecting taxpayers is brand new. And I'm not afraid of that discussion, it's just worthy of a lot of discussion. And so do you think ACOs should have to bid for the right to manage Medicaid funding?
Well, I think if an ACO is going to participate in the system, certainly they have to be approved by the state to provide the services that they're going to provide in whatever region of the state that they're going to be providing that in. As far as how this will be implemented, I think we're all trying to just decide exactly how that works. If it's going to be in different regions, let's just say the state's divided into 8 regions, and that's the way that it looks. I believe that an ACO probably would be bidding on, or at least providing services in a given region.
Do you think it's reasonable then for ACOs to put money into the Department of Insurance to make sure that they can pay their bills?
I think that I would be happy to entertain further discussions on what an ACO looks like, defining it. I'm not prepared today to say that an ACO is an insurance company should be fully at risk today. I think it's a new entity and it's an evolution of the fee-for-service footprint, and what we're trying to do here is provide innovation and dollar savings to the state. I understand concerns if a Medicaid ACO has not operated, but I will say again that there is experience with Medicare ACOs, so the model does exist out there.
Okay, so on Medicare ACOs then, how is it determined if an ACO is denying services or acting outside of their duty?
Let me ask you to ask that question one more time.
Okay, so now you're saying, since we don't have any data on Medicaid, but we have Medicare ACOs. So with regard to Medicare ACOs, how is it determined that they're denying inappropriately or acting outside of their duty?
I don't have the answer for it yet. I'd be happy to get that for you, but I would ask you, Senator, a question with all due respect. Why would we not want to have innovation in the Medicaid system today, have competition in the Medicaid system? Why would we not want to try new and innovative processes that provide savings?
Right, since you asked the question, my answer is check. I agree. The issue though is we're moving the most vulnerable population that I am very sensitive to into a program that you're advocating for here today that has no track record with regard to Medicaid. And then as we get into specific questions about Medicare, and you're saying that there is a panacea with Medicare, but we don't know what they do with regard to oversight. We don't know who's responsible if they don't pay the bills. There's just a lot of unanswered questions. And that's the purpose, I think, of hearings. Some of these hearings, there's not a lot of questions, but some are worthy of a lot of questions. And so you know, with regard to managed care organizations, there's a lot of criteria, a lot of oversight currently. But this is a brand new model. And I'm sure we'll have more, and I know other people are gonna have more questions, but the construct of my long list of questions has to do with who's responsible if an ACO, which we're creating now, it doesn't exist anywhere else. Who's responsible if they don't pay their bills? How do we know if they're not denying care to people who need it most? What are the repercussions? And I just don't hear a lot of answers to those questions.
Let me just point you back to several years ago, too, when we went through this debate in 2007. And we did a major reform overhaul of Medicaid. I believe it was Senator Charles Shields who had Senate Bill 567. One of the elements of that bill, which incidentally changed the name of Medicaid to Missouri Health Act, was to establish a statewide ASO, or at least to allow those to develop as an account for service organization. And so what I'm trying to get to is although an ACO would be a rather new element to Medicaid, the idea of differing products and ways to deliver service is not new to the discussion of Medicaid reform.
Do you think that pursuing maybe a pilot project may be a better course of action as opposed to moving wholesale everyone into a sort of uncharted territory?
I would argue that there was a pilot that has been in existence for over a year in Missouri on healthcare homes, which has been a great example of coordinated care, which is what an ACO is. And I would argue that it makes sense for the state to consider all the options, one of which I think makes sense is an ACO. So I would say that further discussion, as you argued, is warranted. So let's continue the discussion. And I would also argue that the state would retain the oversight and ability to enforce any laws or payment to providers, any of the concerns that are raised. I think the state would retain the authority to do that, and if we need to put more language in, as you are, I believe, are arguing for, then I'd be happy to discuss that further. Or obviously, there would be quite a few regulations, I think, written by the State Department and Medicaid to enforce and execute this bill. But I do think that from a principle standpoint, the issue here is how are we going to deliver care to the individuals that we're arguing are the most vulnerable and are the most expensive. These individuals that you're talking about. And it's been clear that the state thinks that it's a good idea for the health home as a coordinated care model to do that. And that is saving money in the state. So that's proven. So if that's the case, and providers are being trusted to do that today, and it's shown successful in a coordinated model, then I don't see why it wouldn't make sense to do that in a little larger scale on an ACO basis, which would be providers coordinating that care as well. And frankly, an ACO model would include an insurance company being a part of that model. An insurance company could be a part of it. It could be, I won't name any companies, but it could be any. It could be one of the managed care companies that operate today. So I think there's a lot of opportunity here for the state for better care management. And I think the principles that we're arguing for, I think that I would believe that the committee and the state would want more competition, reduced costs, efficiencies, all can be accomplished with varying models. And I don't think a one-size-fits-all will do that.
Okay, thank you. And I just want to center on this is a a Herculean task, and so I appreciate you bringing ideas forward. I know that there's a lot of people from a lot of areas here.
We want to talk more about the responsibilities.
Yeah, thank you.
Thank you. We're getting close to the end of our meeting, and I have Senator Holton, Senator Stonewall, Senator Griffin, that has questions of this particular witness. And if they're long questions, what I plan to do is we're going to just recess until next week for a posted time. We may in fact look at trying to do an afternoon or evening meeting. And I do apologize to those that have not got to speak yet. One thing I want to tell you that we got a lot of emails last night from folks that cannot attend, and we're going to get copies of all of those in the package for each senator, agree or against, doesn't matter. So you're going to be heard, and senators do read them. So I think what I'll do is entertain a motion to go into recess, and we'll try to find maybe an afternoon or evening opportunity to continue the discussion. Okay, yes, go ahead.
Just real briefly, my question is very brief, and I think that it's probably going to require some thought, so I want to get it out there. Senator Romine, in his opening statement, said that he was interested in entertaining transparency on this legislation that Dr. Schrock has been supporting. If we were able to adopt transparency on this legislation, would that change your support of the bill?
Yeah, I think if you look at the last dot on the document I distributed, we think that transparency is something that's needed in the system. In fact, I think that as I read the bill, there's a lot greater transparency on the managed care companies that are there to provide more data to the state and to you all. So no, obviously we can argue about the details of what that looks like and how it is executed. I'm sure we will, but certainly are open to transparency. I'm assuming that you're talking about Medicaid. You're talking about
yes. I have a broader transportation or transparency piece of legislation. I'd like to have a hearing in this committee at some point in time. And Dr. Schrock has transparency as well, and it could be broader than just the Medicaid population.
We'd be happy to entertain those discussions.
Thank you.
Okay, that'll give you the time.
Motion to recess.
We have a motion on the floor to recess, and we do have Senator Chappelle and all for 29 for a second. And then we'll kind of fill in that. And all those in favor say aye.